Good morning, and myself, Dr. Jignesh Ladumor, and today we are discussing psychodermatology. It is important topics. It relates psychology, psychiatrics with the skin disorders. Under the guidance of Dr. Manu Parmar sir, Professor and Head Department of Psychiatry.
Okay.
Psychodermatology is on the interdisciplinary field connecting dermatology, psychiatry, and psychology and the behavioral medicine. It deals with the skin disease that are influenced by the psychological factors and the psychiatric disorders that manifest through the skin and the psychological problems caused by the visible skin disease. The relationship is bidirectional from mind to skin.
Right.
Stress, anxiety, depression, and the emotional trauma can initiate or worsen the skin disease. And the skin to mind, it the chronic or disfigure skin disease can lead to anxiety, depression, and the social withdrawal and the reduced quality of life. First of all, the skin and brain connection. The skin and nervous system have a close embryological and physiological relationship, and the skin contains sensory nerve and the neuropeptides, immune cells, hormonal receptors, neurotransmitter system, and the complex microbiomes. And the psychological stress activate the hypothalamic pituitary adrenal axis and the sympathetic nervous system. This can alter cortisol and other stress hormones. And the inflammatory cytokines, immune responses, skin barrier functions, and the sebaceous gland activities, and itching and the pain perception and wound healing. Thus, the chronic stress can contribute to self perpetuating cycles. Stress lead to neuroendocrine and the immune changes. It will lead to skin symptoms and the distress. And again, it's increase the scratching and the harmful behaviors, which worsening the skin disease will lead more stress. So second one is major category of the psychodermatological disorders. A useful clinical classification is into the three broad groups. And first one is a psychophysiological disorder.
Okay.
There is a genuine dermatological disease, but the psychological stress can trigger or exacerbate it. Example, psoriasis, atopic dermatitis, acne, urticaria, rosacea, alopecia urticaria, eccrita, and the hyperhidrosis, herpes simplex reoccurrence, pertussis, and the some form of eczema.
Okay.
Here the psychological treatment is adjunctive and not a replacement for appropriate dermatological treatment. Second one is a primary psychiatric disorder presenting through the skin. The skin manifestation are largely produced by psychiatric and behavioral mechanisms. Important example include excoriation disorders, also called the skin picking disorder. The patient repeatedly picks, squeeze, and scratches or manipulate the skin, produces excoriations, erosions, ulcer, scar, and the hyperpigmentation and secondary infections. Patient may experience increasing tension before picking and relief or the gratification award. Treatment may include cognitive behavioral therapy, habit reversal training, SSRI in selected patients, and N-acetylcysteine in appropriate cases, and the dermatological wound care. Trichotillomania mania,
Trichotillomania.
a compulsive urge to pull out hair, leading to irregular patches of hair loss and the broken hair of wearing lens and the scalp or eyebrow involvement and sometimes ingestion of hair. Behavioral therapy, especially habit reversal training, is an important treatment. Dermatitis artifacta, the patient deliberately produce skin lesions and usually while denying or counseling the behavior. Lesions may be bizarre, geometrical, sharp-edged, or the inaccessible or unusual in distribution. Management required a non-contributional therapeutic relationship and the careful exclusion of the genuine dermatological disease. And fourth one is a delusional infestation. The person has a fixed belief that the skin is infested with organisms or foreign material despite lack of objective evidence. The patient may report crawling sensation, biting, stinging, itching, and the specimen sign. It means bringing material believed to the contain the organisms. Treatment commonly involved antipsychotic therapy, particularly specialized guided use of agents such as the risperidone and the olanzapine. Fifth one is a body dysmorphic disorder. The patient become excessively preoccupied with a perceived defect in appearance that in minimal or not observable to the other. Common concern include acne, scar, nose, hair, skin texture, facial asymmetry, and pigmentation. Patients may repeatedly seek dermatological or the cosmetic procedure but remain dissatisfied. Screening for body dysmorphic disorder is a particularly important before a cosmetic procedure, and the psychotic disorder secondary to skin disease, in which skin disease can have profound psychological consequences, and common consequences are like anxiety, depression, social anxiety, low self-esteem, shame, stigma, social isolation, sexual difficulties, and sleep disturbances, occupational impairment, and suicidal thought in severe cases. Conditions particularly associated with the psychological burden include psoriasis, severe acne, atopic dermatitis, vitiligo, alopecia areata, uh, and the severe eczema, chronic pertussis, and the scarring disorders. The visibility and the chronicity of the skin disease often magnified its psychological impact. Fourth one is each and its psychological factors. Pertussis mean each is
Itching. Yeah.
itching is
Yeah.
one of the most important area of the psychodermatology. Stress and anxiety can increase the perception of itch, and scratching can temporarily reduce the discomfort, but subsequently cause itching. It leads to scratching and skin damage, which leads to inflammation and more itch. This is known as a itch scratch cycle. And the chronic itch can causes insomnia, irritability, anxiety, depression, poor concentration, and reduced quality of life. Psychological interventions such as relaxation technique, CBT, mindfulness, and habit reversal approaches can sometimes be useful alongside treatment of the underlying dermatological causes. And fifth one is a stress-related skin disorder. Stress may aggravate several dermatological conditions such as psoriasis. Psychological stress may precipitate or exacerbate psoriasis in susceptible individuals. Second one is atopic dermatitis. Stress can worsen itching, scratching, inflammation, and the sleep disturbances. And third one is acne. Stress can influence inflammatory pathways and behavior such as touching and picking lesions. And the alopecia areata. Stress is frequently reported around the episode of hair loss, although alopecia areata is a fundamentally an immune mediated disease. And the hyperhidrosis, anxiety, and the emotional stress can markedly increase the sweating, creating a feedback loop of embarrassment. It leads to anxiety and increased sweating. Urticaria, in which stress may worsen symptoms in some patients, although physical and immunological triggers must still be investigated. Now, sixth one is the neurotransmitter and the psychodermatology. Several neurotransmitter system participate in the brain-skin interaction. Important mediators it include serotonin, dopamine, noradrenaline, acetylcholine, substance P, and corticotropin-releasing hormone. And last one is endorphin. This system can influence itching, pain, inflammation, stress responses, sebaceous activity, sweating, and skin vascular responses. This help explain why medication affecting the nervous system can sometimes have benefits in selected dermatological condition. Seventh one is assessment of the psychodermatological patient. A good assessment should be dermatological, psychiatric, and psychosocial, in which a dermatological assessment ask about the onset, duration, distribution, itching, pain, triggers, and the previous treatment. And other are medication that are used, allergies, infection, and other systemic symptoms. In psychological assessment, we screen for anxiety, depression, obsessive compulsive symptoms, and the body image concerns, delusion or compulsive behaviors, trauma and stress, and the sleep disturbance. And third one is a behavioral assessment. It asks for do you scratches or pick the lesions? Do you check your skin repeatedly? Do you spend a lot of time thinking about your appearance? Does stress make your symptoms worse? Or how much time do you spend treating or examining your skin? This question we are asked for a behavioral assessment. And the important diagnostic principle, in which a crucial rule is never assume that a skin complaint is psychological simply because the patient appear anxious or distressed, and the organic, dermatological, and the systemic causes must be appropriately excluded. For example, itching may result from the eczema, psoriasis, scabies, drug reaction, liver disease, kidney disease, hematological disorders, endocrine disorders, neuropathic disorder, and other systemic malignancies. And the psychiatric assessment should be therefore complement, not replace, and the medical investigations. And 9 1 is a treatment of the psychodermatological disorders. Treatment is often multidisciplinary. First one is a dermatological treatment, depending on the condition, like topical corticosteroid, calcineurin inhibitors, antihistamines when it indicates, and antimicrobial treatment, phototherapy, systemic immunomodulator, biologic therapy, wound care, hair loss treatment, and acne treatment. And the exact treatment depends on the underlying diagnosis. Second one is psychological treatment. It is important approaches include cognitive behavioral therapy, helps identify and modify thoughts, emotions, and the behavior contributing to that symptoms. And the habit reversal training, particularly useful for the repetitive behavior such as skin picking and hair pulling. And mindfulness based approaches, it can help a patient recognize stress, itch, and the urges without immediately responding through scratching or picking. And the relaxation techniques like breathing exercise, progressive muscle relaxation, meditations, yoga, and biofeedback. Third one is the psychiatric pharmacotherapy. Depending on diagnosis, and psychiatric may use SSRI, other antidepressant, antipsychotic, and anti-anxiolytic strategy, and the agent targeting compulsive behaviors. Medication should be selected according to the specific psychiatric diagnosis and the comorbidities, interaction, and risk profile, rather than the simplify treating the stress.
Thank you, Dr. Jignesh.
Thank you.
Nicely presented. Okay.